All right. Good morning and welcome to the Prostate Cafe. Can everyone hear me? Okay. All right. Well, I'm Dr. Dattoli. I'm here to answer any and all questions you may answer. I'll try to answer to the best of my ability. I do want to thank Johnson & Johnson for providing breakfast to us all today. Um, they have some very new and interesting products for prostate cancer. We commonly use one here called apalutamide, also known by its brand name Erlita. And these are interesting drugs. They take hormones to a different level. So, primary hormonal therapy, which is what we have been giving for a long time, suppresses the central axis, our brain's way of producing uh, the male hormone testosterone, and it blocks it. And that's what primary hormonal therapy does. It blocks it at the level of the brain. But this, and in doing so, you drop testosterone to zero. In contrast, with the newer generation, like the drug Erlita, the generic name is apalutamide, it actually doesn't do that. What it does do, however, is it at the level of the receptor of the cancer, it blocks that and just that. So men who do take this drug, their testosterones don't go to zero. It basically shouldn't affect the testosterone at all. So that's a big advantage. But we commonly use it in conjunction with the primary hormonal therapy. And um, at this point in time, we don't feel comfortable just giving the second line or the apalutamide, or also known as Erlita. But we'll see what happens with time and studies and clinical trials. But at this point in time, in fact, the rep here was just showing me a recent article just came out suggesting that it's superior to doxycycline, which is a chemotherapeutic drug. And I'm really glad to see that just because, I think we're going to get away from chemotherapeutic drugs, and maybe 5 years from now, uh, we won't hear about them anymore, although there'll probably still be a role for unusual cancers of the body. But anyhow, I'm here to answer any questions. Do you have any at this point in time?
I do.
Yes, sir.
How often do you recommend any hormonal therapy?
So this gentleman's asking about how often and when we do recommend hormonal therapies. I'm not a big hormone bug, and so I'm the one who gives the least amount of hormonal treatments. But I do know when it's advantageous for a patient, and the data suggests that patients who have higher risk prostate cancer can benefit from hormones given in conjunction with a radiation treatment course. So when we talk about hormones in this setting of prostate cancer and localized prostate cancer, or even local regional prostate cancer, we're talking about giving it in conjunction with a radiation treatment course. And many places will give long-term hormonal therapies in that setting, 18 months to up to 3 years. I don't do that. And if you really look at the data closely, and I have, you'll find that the true benefit of hormones is when the radiation is actually being delivered. And so there have been studies using hormones before radiation, during radiation, after radiation, before and during and after. But if you really call it all out, you'll see the data is very strong with the during phase of radiation. Having said that, you have to understand that radiation may, your treatment course may end today, but the effects of radiation may continue. And there is actually a small tail going out a year, in some studies, even a year and a half. So, but again, I try to tailor the hormonal regimen to each patient and their cancer characteristics. Now, in patients who have more advanced disease, meaning known spread to lymph nodes and lungs, bones, etc. In those patients, there's a very clear role for hormonal therapies, and maybe not even with radiation. But the best way to suppress cancer that has spread in prostate cancer is the use of hormones. And again, in the patients who have disease that has disseminated or spread to other parts of the body, that's where we do like to use the combination approach of primary hormonal therapy, which, as I was saying, shuts down the production of testosterone entirely, and also a next generation drug like Erlita, and there are three others now, and Erlita is one of the latest. There's also a drug called Nubequa. There's one called Xtandi, and Zytiga, and these are all relatively new drugs. They weren't around 10 years ago, and so they're very effective. When you look at the combination approach of radiation and hormones, it appears that what the hormones do, you see, radiation creates free radicals. Free radicals injure the cancer cell at the level of the DNA. It actually fractures the DNA of a cancer. Hormones actually work nicely because cancers always try to recover and repair and do their best. They're sneaky, wanting to get that DNA strand back together, and hormones don't allow that to happen. So if you look at the data, strictly speaking, the patients who could benefit from hormones with localized prostate cancer are those having the higher grade tumors, and that would be a Gleason 4 plus 3 equals 7, a 4 plus 4 equals 8, 4 plus 5, or 5 plus 4 equals 9, and finally a 5 plus 5 equals 10. Those are the more aggressive prostate cancers that data has clearly demonstrated an advantage. Now, there are patients who have lower grade tumors, 3 plus 4 equals 7, sometimes even 3 plus 3 equals 6, but very high volume. They too can benefit from a combination of the radiation and hormones. But as I started by saying, I'm the one who gives the least amount of hormones because I do recognize that they have a fair amount of side effects. I mean, the primary hormonal therapy, the one that shuts down production of testosterone, basically puts you into the male menopause, and that's what it is. And, any desire for sex, your libido, first thing gone. And then there's other things like hot flashes and things that ladies have experienced. But the good news is that it's typically temporary. And once they're completed, then your body gets on with producing testosterone and you feel good again. So that's kind of the basis for using hormonal therapies.
And you said you always use the secondaries with the primary, or not always?
So he's asking, do we always use the second line, next generation, they're called hormonal therapies, along with the primary? Generally speaking, yes. If we're going to use the second line, we're going to be using the primary. If we're using just the primary, that may be enough for patients having localized prostate cancer without spread of the cancer. The interesting thing about it is, I've told you just a few minutes ago that the Erlita and drugs like it, they don't take your testosterone away, they just block it when it wants to touch the cancer receptors, so they work very precisely. However, the data right now still supports primary hormonal therapy as the sensitizer for radiation, the one that causes the radiation to work better because of the inability for the cancer to repair. And that 1 plus 1, hormones and radiation can actually equal a bigger number, 4 or 5 or 6. That's the data. And, some men refuse hormonal therapies, and I fully, understand that they do have side effects. And I don't mandate it because if you look at the data, it's not generally a huge advantage, but there's an advantage. And even the men who are going to refuse it, I still want them to know that in their case, there would be a role for it. And I tell them what that role is just so they can make a good decision about it. We also have found with the primary hormonal therapy that, again, we use it for a shorter period of time. I've published extensively on locally advanced prostate cancer, and that means disease in the prostate, but which has spread outside immediately of the prostate to the lymph node regions or the tissues around it, or in rectum to the bladder, things like that. And I've published data that there was really no advantage beyond 4 to 6 months of hormonal therapy. And, so that's my data. And so if you're being treated here, that's my data. Now, that may be the case for other reasons. For example, we know that patients with radiation, and when you combine two types of radiation, one being a version of external beam radiation, that could be protons, neutrons, photons, or electrons. That's where the radiation machine is shooting it from the outside and precisely putting it on the inside. But when you then combine brachytherapy or seed implantation with that, you get a lot more out of it. And you get a lot more tumor cell kill. And again, the reason for that is, well, the first version of radiation, the external beam radiation, caused the injury of the cancer cells. And they're smart, though, and if you continue to do external beam, external beam, external beam radiation, there are some we call tumor clonogens, which actually start looking to resist what you're doing. And again, it appears that by doing the brachytherapy, it's fooled. You've changed the menu for the cancer. And there's data, and I've published extensively on the combined modality approach. And there's other centers currently, publishing, and that includes the University of Pittsburgh. There's a large study called the Ascend RT trial, and that's a North American randomized, controlled study. It's a very well-run study, and they've been publishing, and they recently published in 2023 that they had a 50% reduction of cancer recurrences in the group that had the combined approach, radiation and brachytherapy versus radiation alone. So having said that, you could see that the radiation plus brachytherapy is an advantage. Well, is that advantage enough to not need hormones? We don't have that data. We just don't. Okay. And, but again, that may be one of the reasons why my own data, 4 to 6 months, was adequate for the vast majority of men. We also use other agents when we talk about hormones here, and other agents which could actually lessen the side effects of the primary hormonal therapy. For example, primary hormonal therapy, as I mentioned, male menopause, hot flashes. So we use an agent called an estradiol patch. And as it sounds, it's put on the skin, and it really does reduce the hot flashes tremendously. And in the same process and in the same breath, it also has its own anti-cancer properties. So you're kind of getting a twofer with that one. Anti-cancer, taking down some of the side effects of radiation, of the hormone, I'm sorry. The other drug that we use a lot of is called cabergoline. Cabergoline is interesting. There's another hormone created by the pituitary axis of the brain called prolactin. And prolactin is really powerful, stimulating prostate cancer. Many think even more powerful than testosterone itself. And so we look to shut that down too. In the process, it really doesn't have any side effects by doing that. So it's a distinct advantage. In fact, cabergoline as a medication used alone can be used for men who are interested in having sex and having more than one orgasm, because that's what it's known to do in men. So we use cabergoline. There are other agents that we use. One of the common ones is called dutasteride, also known as Avodart. Again, Avodart is not a hormone at all, but it doesn't allow whatever testosterone is left over to convert to another molecule called DHT, dihydrotestosterone. Again, dihydrotestosterone is an agent, or is something in our systems that actually, again, grow prostate cancer. So we use that It's not a hormone, and it has another side benefit, and that is that it grows hair on the scalp. So, nothing lost. And so, yeah, so these are agents that we use commonly. They don't cause side effects. Some of them lessen the side effects, but maybe the total package reduces the need to use long-term hormonal therapies because it is a little more compact, a little more intense, going at different angles to stem the cancer.
So that last one you mentioned was protein.
There you go.
Might do it.
Definitely, definitely. Hmm. Its little brother is called Proscar, also known as finasteride, and finasteride is also very commonly used for male balding, and that's perhaps the most common use for it. In addition, finasteride or Proscar is used for benign prostatic hypertrophy because another benefit of it is it shrinks down the prostate size. And so for men who have, obstructive urinary symptoms, frequency, urgency, getting up more at night, the finasteride and the dutasteride, its bigger brother called Avodart, the first one I talked about, both shrink down the prostate. In some men who have larger glands, but they don't necessarily need hormones because it's not that aggressive of a cancer, but their gland is large. So we use the Avodart, also called dutasteride, because again, it appears that when you give it simultaneously with the external radiation or the brachytherapy, it shrinks the prostate gland down quite a bit. And we like that, and men like that, and find in the future their urination profile is improved.
Permanent shrinking, or slowly it regain its volume?
So he's asking about, is there any permanency, or does the gland just rebound right back to being large? The answer is, if the agents of finasteride or dutasteride are used alone, without radiation, without hormones, then, and typically we recommend it for 6 to 12 months to shrink the gland down, it will recover. The gland will resume its size. It takes years, though. In contrast, patients who get the dutasteride, finasteride, and or hormones with the radiation, it'll shrink down and stay that shrunk forevermore. And, I've measured prostate glands for, in follow-up. I always follow my patients for years, and it just doesn't grow back again. And that's a really positive benefit of the combined approach of radiation and those drugs. Yes, sir?
Good morning.
Good morning.
I appreciate what you do and all your research so much. And thank you for that, and for keeping me alive and cancer-free for almost 10 years. So
thank you. I'm glad.
I had some friends from Oklahoma that were up visiting, and they were mentioning that people, in the country and out in the the backwoods and stuff there, they believe that ivermectin and bendazole is curing cancer. And is that just crazy? Is it a myth? Is it, because I believe that's dog warmer and livestock warmer, right?
Yes. So he's asking the question about the role of drugs, which are called antiparasitics or antihelminths, in treating cancer, generally speaking. And the three big ones would be ivermectin, which many of us have heard during COVID. We found that ivermectin could have advantages, but there's also fenbendazole and mebendazole, and these three agents do have anti-cancer properties. However, they're small. It's not like you just said, curing prostate cancer or curing malignancies. Sure, there's data, or there's always a case report of something where a person's said he took these drugs and got rid of his cancer. But I've been following patients for a long time who have been taking those drugs, and I'm not opposed to them at all. They do have anti-cancer properties, but they haven't been studied clinically in humans, but still they do have anti-cancer properties. And what I have identified is they don't really have a lot of side effects. So because of that, I have no problem with men, using them. I do track the liver function because they can influence the liver a little bit, and we track that just to make sure there's no caustic effects from the drug on the liver. But they do have anti-cancer properties. But I think that the concept that you can take them instead of, you know, treatments like radiation, surgery, chemotherapy, it's just not the case. And I have unfortunately seen so many men now who have banked on those things, those drugs, to take care of their cancers entirely. And then by the time they get to me, their cancers have spread all over the place. Again, I'm not opposed to them. They do have anti-cancer property, but so do other things. For example, a simple drug like metformin, which is used for diabetes, has anti-cancer properties. And we've actually moved away from metformin because we use that as also our package that I was mentioning earlier, where we're using a lot of agents with the hormones. But we've moved away from that because it can have some GI side effects. And now we use berberine, which basically, again, if you look at the molecular structure and and the way it works, it's very similar to metformin. It doesn't appear to have those GI side effects. So again, if you look at berberine, you'll probably find, or metformin, they have anti-cancer properties too, and maybe just even a little more than the ivermectin and the fenbendazole and mebendazole. So I think that they're not a panacea, those drugs, but they can be used adjuvantly along with other, anti-cancer agents. Any other questions? Yes, sir.
How does I have a friend also that using only is it proton treatment as opposed to any radiation or anything like that. How does that contrast and compare?
But he's asking about a type of external beam radiation that we call proton therapy. Protons have been around for a very long time, and their potential benefit is that they can be more precise than other types of radiation. So when we talk about external beam radiation, we're talking about different types: protons, neutrons, photons, electrons. They are all externally delivered by these big machines called linear accelerators. And protons, again, are purported to be more precise, and in fact have been used for a very long time for tiny tumors of the brain, tumors behind the eye. I actually worked on the Harvard cyclotron for a while, a long time ago, specifically for those types of tumors, small tumors in different parts of the body. Around 2014 through 2016, protons started to be used for prostate with the same purported advantage, and that is that, it could be more precise, and, the prostate is entangled by all these surrounding organs, your bladder and your rectum, and, the urogenital diaphragm below it, and the neurovascular bundles. And so it was purported to have an advantage because it was more precise. And in fact, back then, 10, 12 years ago, insurance companies were paying a lot of money for proton therapy. Even Medicare was paying $150,000 for proton therapy for the prostate. What happened was, as you can imagine, if it's being reimbursed, 4 to 10 times the cost of other types of radiation, every place in America wanted to have one, and they started popping up across the fruited plain. However, by 2018 and even in 2026, there was another study. And what they did is they said, well, let's look at protons versus another type of radiation called photons and see just how much better they are. And it started around 2018. And as I say, there's some very, very recent studies. They came to find, when they looked at one versus the other, and they did, strict criteria, they were randomized, and who gets what. One guy gets protons, the other way photons. There was no advantage at all with the protons, and in fact, the data suggests that there were more side effects from the protons. With respect to, one study showed increased GI, gastrointestinal toxicity. Another study showed increased GU, genitourinary toxicity. Well, you can imagine the insurance companies got wind of this and they just dropped it like a hot potato. They said, we're not paying for protons anymore if it's no more advantageous than, radiation that's being treated at a much lower dollar count, a fourth of the price or a third of the price. And that's what happened. And so many of the centers that were around the nation closed up that were using protons, and only the largest facilities, the big universities, continue to use them because, after all, they could use them also for tiny tumors of the brain, small tumors behind the eye, and other potential options for different types of cancers aside from prostate. So I know University of Florida Shands has a proton accelerator. I was actually a consultant there for a little while. And, again, if you could look around major universities, some of them will still have proton therapies. But again, they're now looking into why is it that the toxicities were higher? Because on paper, it looks great, but in reality, it doesn't. And that's what the data shows. And, you can go home and Google that, protons versus photons. There's a 2026 article, and we'll just show the same thing. No advantage and a little more side effects on the protons. Anyone else? Okay. Well, we can talk about some other things. So cancer, by and large, has different ways that it can happen. One of which is, and you probably have heard it by now, is your diets, right? So certain diets have been clearly identified to promote cancers. Other things, like obviously smoking and alcohol, have been identified to promote cancers. And we call those things environmental, potential ways of causing cancer. And they're profound. Men who smoke and drink can get head and neck cancers and lung cancers, and almost every cancer in the body has that, negativity with smoking and drinking alcohol. Prostate, lesser than the rest. However, it's still shown that, smoking and drinking alcohol can increase the rates of prostate cancer. But the other side of it is genetics. So, we all have these genes, and we all hear stories. My mother, she lived to 99 and she smoked every day of her life. Well, that was because her genetics are really good. Okay. But the genetics could also be really bad. Okay. And we now know, for example, and we'll focus on the prostate, that it's related to certain other cancers. So the cancers that are most related to prostate cancer include breast and ovarian cancers in women, colorectal cancers in men or women, and pancreatic cancer, but also melanoma. So those are the ones that, we pay attention to because they are related to prostate cancer. And we, if you've spoken to me, I'll always be asking you, do you have any first degree relatives or even second degree who have, increased or history of those particular cancers? And that's part of the whole genetic scheme. Now, having said that, there's also, so you're at increased risk if you happen to have relatives with any of those cancers. You're at increased risk for developing prostate cancer, okay? Or if someone has prostate cancer, is at increased risk for developing any of those other cancers. But there's also something called germline, and now we're looking at the DNA, the genomics, and it may be that every single cell in your body carries a germline mutation. And the most popular one with prostate cancer is one called BRCA, BRCA, and there's a BRCA1 and a BRCA2. And that's really important because if you have a BRCA1, BRCA2, and especially the BRCA2, then you're very, likely to get one of those cancers, and you have to be surveilled, not only for prostate cancer, but for breast and ovarian and pancreatic and colon, and you just have to be on it. And there are centers now that actually have specific clinics just for germline tumors. And so it's very important. And, we often talk about cancer families. And, you may have heard like, oh, there's a family and everybody in the family's got cancer. It was probably because they harbor a germline mutation. So again, they were born with it. They didn't acquire it through, environmental anything. They were just born with it, and they have to be monitored. Now, they don't all get, other types of cancers, but hopefully if they're surveilled, if they do get other types of cancers, they'll be, found early on when it's curable. Now, having said that, DNA mutations, well, cancers themselves make mutations. We call that somatic mutations. It also goes under another larger umbrella called molecular mutations, and so that when we look for them, we call it molecular profiling, genomic profiling, somatic profiling. And what it basically means is, okay, you got this cancer, whatever kind of cancer it is, prostate, lung, tongue, brain, breast, gynecologic. Let's study the cancer itself and see if it's showing something different from the rest of your body. It's not genetic. It's something only that the cancer has made and is thriving because of it. And the reason why that's important is when we test for that, and if we find a select mutation to your cancer, there may be agents that we can use to target that specific cancer. We call those mutations actionable, meaning we can take action because you have this specific somatic mutation. Again, it's not all the cells in your body. And the reason why that's advantageous is because it can, again, be very precise because it's only going after the cancer. Okay. And so we do that. And now we're doing another thing called next generation sequencing. And there are numerous companies. It's a space that's getting busier and busier with companies that are looking to do these so-called molecular profiling or genomic profiling. And so that's what it's all about in terms of, can we use an agent to target your cancer? Now, in some cases, we say, well, with prostate cancer, you have this genomic somatic mutation, okay? And we can use different drugs, immunotherapies, PARP inhibitors, a whole class of drugs to target it. However, you still could be treated with, primary therapy, whether it's surgery, radiation, chemotherapy, very effectively. And we think you should do that because they have the highest chance of curing you. And if they don't work, well, we got a backup plan. You have that in your back pocket. And that's the potential agent that could target your specific cancer that's called, because of it having a somatic mutation.
In all
Yes.
the categories that you just kind of mentioned, do black men fit in one of those? Because I know we're like 75% more likely to get prostate cancer.
So he's asking about the risks associated with these, what I've been talking about with African American men. Well, what we do know is with prostate cancer, Black men have a twofold increased rate. And at this point in time, we haven't specifically identified that it's because of those germline mutations or the somatic mutations. So really right now, all we can say is that you do have an increased risk for developing cancer, and we need to be, paying more attention to Black men because of that. It also is interesting that Black men who get prostate cancer, stage for stage, it behaves a little more aggressively. And we don't quite know why that is, but that it does. Okay? Yes, sir.
Long story short, a couple weeks ago, urination, really couldn't go, but I had the burning sensation. And then I over-the-counter pill that did help. But then recently I've been really urinating a lot. Like I say, day before yesterday and yesterday. And I tell you, I was up 6 times last night, easy. And, it's like you feel like you urinate and you can't urinate yet. And the burning, sensation, really uncomfortable. So I just wanted to say that. I mean, is there any?
So
radiation and whatever.
Right. So the problem with prostate cancer and prostate glands is that it's just such a busy location, and it has the prostate urethra going right down the center of it, and it has the bladder sitting right above it. And in some men, there's actually a portion of your prostate that's protruding up into the bladder. So radiation, before it causes the shrinkage that I've been talking about, along with hormones, if that's the case, um, before it does that, it causes inflammation. And so what happens is, we're not treating the bladder, and in fact, the urethra, which runs right down the middle, we lessen the dose to it to try to lessen those side effects. But what it tends to do is, at least temporarily, is share its inflammation with the surrounding areas. And that is the urethra, which runs right down the middle. So prostate gland is shaped something like this. It's actually somewhat heart-shaped. The prostate urethra that all the urine has to go through goes right down the center of it. And so by treating, and we have to treat the whole gland, we have to treat this area here because there's cells that are typically cancerous or going to be cancerous very close to the urethra. Now, what we try to do here is we try to treat the periphery area, because that's usually where the bulk of the cancer is, and to lessen the dose to the central structure, which is the urethra. But we can't turn it off, because if we do, then cancers will start here over time. And so we just can't do that. So what happens is these areas of the prostate, even the peripheral zone, get a little bit inflamed and then share it with this urethra. Also, right here is a big muscle, and that big muscle is actually joined to the bladder, which is bigger. And it's just the bottom of the bladder has a big, thick muscle right here. And we call that the internal sphincter muscle. And actually, most men who have prostate issues, and they may find, they're getting up more at night, their stream is weak, and they got to go more urgently during the day or frequently during the day. Most cases are not because the prostate is pushing into the urethra, because most of those symptoms I just mentioned are from benign prostatic hypertrophy. As the prostate gets bigger, those symptoms come, and as we get older, the prostate gets larger. But I think it's just easier for doctors to explain that your prostate's getting bigger, and so it's pushing on, it's pushing on the urethra. And but that's not really the case so much. It's mostly that the prostate is getting bigger, and instead of these walls being here and the bladder being there, it's actually protruding up and protrudes into the bladder, and it drives the bladder crazy, and it specifically bothers that big muscle we call the internal sphincter muscle, and it agitates it, and it's compressing it. And this big sphincter muscle is the control center for your urination. You've been relying on it your entire life, but if it starts getting protruded into, it's bothered, and it's agitated, and it's not working in harmony like it usually does. All of this area is comprised of smooth muscles, and smooth muscles like to flow and, really rhythmically. And if you start pushing into the bladder, then what happens is it kind of agitates it, and you lose that methodical flow. And so when you do urinate, you don't urinate at all. It's just a little bit of urine comes out. You got more to get rid of, and that's why you got frequency of urination. Now, for the same reasons, with treatment of prostate cancer, you're causing inflammation of these areas, and they also protrude, or end up bothering the bladder, because the bladder is so sensitive. Again, we're not treating the bladder, we're treating the prostate, but it's a secondary effect. Some men, and it's not a small number, have part of their prostate which actually protrude up like this. And again, this is just a benign phenomenon, and we don't treat it. But by treating the rest of the gland, it gets inflamed and then shares it with this part of the prostate, which is protruding right up into the bladder. And again, it just causes frequency, getting up more at night, a weakened stream, and urgency. So,
Started the dark too yesterday, actually.
okay.
That's when this really got worse.
Yeah, it'll get better soon. Yeah, you're going to find over the next week or two, it's going to get better.
And
Now,
this ain't gonna be a future.
no, it's a temporary thing because the inflammation is temporary, definitely. So the class of drugs that tends to be most advantageous, you're probably on, I know you are, is a drug called Flomax, also called tamsulosin. And what it does is it relaxes the smooth muscle of the prostate and the bladder neck in an attempt to make things work more rhythmically and for the striated muscle to not be agitated. So tamsulosin, also called Flomax, is just one of a larger, group of drugs called alpha blockers. And there's others. So if a person's not responding to the tamsulosin, we up the ante and we go with another one called doxazosin, also known as Cardura. If doxazosin doesn't work, then we go to the next level called terazosin. So it's a stepwise upwards in terms of the ones that we try to use to mitigate the side effects of inflammation. And it is temporary. And in fact, what most commonly happens is down the line, because the prostate shrinks down and there's no more inflammation in time, then you urinate better. So, if those men of here that have been treated will know that we often, and in other places do too, urologists will do a score. It's called AUA symptom score, where we ask you, how many times you get up at night, during the day, all these different questions. And I've noticed that what you come in with, and later on, when I see men in follow-up a year or 2, 3, they're better. They're much better. And that's the common situation. So better days ahead. Okay. Is there anyone else? Yes, sir.
Is there a role for water fasting? Question 1. Question 2. Are you familiar, or do you have any comments about Tom Seyfried and metabolic ideas about the cause of cancer?
Excuse me, he's talking about some other pathways, that cancers are caused. I'm not familiar with water fasting. I'm familiar with the metabolic syndrome, but I can't say I am.
Well, that was a separate subject. So the second subject would be, are you familiar with Tom Seyfried's work at Boston College regarding the metabolic theory?
He's asking about it, Dr. Siegfried. I don't know him. Sorry. I'll look it up.
Seyfried, S-E-Y.
Seyfried, okay.
S-E-Y-F-R-I-E-D.
Okay, I'll look it up. Okay, is there anyone else? Okay, yes. Yeah, so she's asking about a group of treatments called focal ablative therapies. The most common ones being cryosurgery or cryotherapy, which means freezing an area, and HIFU, meaning heating an area. And I've done those extensively up in New York. And what they do is, so if a cancer is here, and that's what the biopsies showed. So in other words, someone's had, numerous biopsies, and they all show that there's a cancer. In this particular case, it's your right, so you would say the right base, the right upper part of the gland. And meanwhile, the biopsies from these areas came back negative. So what you can do is you could put a probe directly into that tumor, and then you use another method of cryosurgery or HIFU, freezing or heating, to send a heating or freezing bulb out to eradicate that specific tumor. Now, it gets dangerous if you come out into this tissue, because that's all those normal tissues that I was referring to. And it works to eradicate that particular tumor. Although I see men all the time that have had that done. I just saw a man, he had 4 in a row. and each one to the same exact location. It didn't go away. But when I was doing it, and I abandoned it, and the reason I abandoned it is because the prostate gland, all the tissues, all the cells have been subject to whatever caused them in the first place. So they've been, whether it's a genetic, whether it's a dietary, whether it's environmental, toxin, pollutant, Agent Orange, whatever it may be, every single cell in the gland, it has been subject to that. And so my experience with freezing and heating, and there's another one, by the way, called Tulsa, where you put and I haven't done those, in the center, and you heat from the center out. But what they do is just ablate that area. Well, all of the cells have been subject to whatever caused this one to happen. And I came to find what happens is it's just an accident waiting to happen for the rest of your gland to become malignant. And so my experience was, let's just say you have a PSA of 4 or 5. You do cryo or HIFU, it goes to 2 or 3 or 1 or 2 for a little while, and then it starts going back up again. And then, you image and you rebiopsy and you find, oh, we treated this one, that's okay. Now there's one down here. And then you treat that one. Oh, this is gone, but the PSA is rising again. You find there's another one here. And that's because all those cells eventually become malignant. And that's the reason why I abandoned it, because the only purpose for doing it is, okay, you can say once is okay from the standpoint of side effects, you shouldn't have a whole lot. So that's good. However, once you get to the second one, you start having problems. And it really does cause a whole lot of scar into the prostate. And that ends up affecting the urethra and even the rectum behind it. And so, again, if it was a one and done, I'd still be doing it. Okay, but I came to find it wasn't a one and done. And the other thing I'm finding a lot of is that men who have that done, and especially when it's done repeatedly, they end up having metastases because the cancers have been around for a long time. The other problem with it is that most prostate cancers, because of the fact the prostate does not have a capsule. Most organs in our bodies have capsules. You can think of it as a membrane, a layer, a rind, a casing. Prostate doesn't have it, even though most everything else in the genitourinary system has a capsule, even the testicles and the penis. Well, most prostate cancers do begin in the edge that we call the peripheral zone and leak out into the tissues around it. Because of that, when you're doing a cryo or a focal ablation with HIFU, you're not addressing the cells out here. And so it's basically an accident waiting to happen. And these guys are then heading off to lymph nodes, which are little organs in our bodies that remove things that are not supposed to be there. And it just so happens the prostate is loaded with lymph nodes surrounding it, and they tend to get involved very early on. So for those reasons, I'm not a big fan of the focal ablative therapies, although it is an option. The problem with prostate cancer is that there's a lot of options, and that generally speaking, it's a slower growing tumor. So everyone can stake a claim and say, yeah, we can treat you, and in the short run, have pretty good results. It's the long run. It's the long run because you want to not only deal with it today, you don't want to ever deal with it again. Okay. And so that's the reason why I do what I do. I was even, I had a lot to do with the pioneering of brachytherapy. And, brachytherapy is where you put these tiny little materials, directly in tumors. And even to this day, it's the most precise kind of radiation that exists. But it doesn't treat the outskirts because it is that precise. And what ended up happening is I started seeing PSA failures, much like I had seen with surgery. If you think of surgery also, you're peeling it off. You can't see those tentacles. You can't see those microscopic elements, and you leave them behind. And they kind of grow back again. Well, the same thing with brachytherapy. I learned it was a great therapy. It equaled every bit as good as surgery, surgical removal, without the side effects of surgical removal. But there was a bigger picture, and the bigger picture is this extraprostatic event and the fact that it goes to these little organs called lymph nodes, which we have more lymph nodes in our bodies than we have vessels. And but again, they're the filters of our body. They're there to remove things that are not supposed to be there. And they're commonly affected by prostate cancer. But you can imagine all the therapies I've just mentioned, HIFU, cryosurgery, and even surgery, and even brachytherapy are not addressing the outskirts and are not addressing those lymph nodes. And when I started to address lymph node disease with the type of radiation we do here called DART, it was a game changer in terms of cure. I mean, a big difference. There's like no question about it. So she's asking about DART. DART is a type of radiation that we are known for here. It's different than other types of radiation. You know, we talked about protons, neutrons, photons, all the other types of radiation. It could be all of those, but we learned a phenomenon about the prostate that's very, very interesting, and that is that it moves a lot. And it moves while you're being treated, okay? And that's a big deal because we're wanting to be really precise. We're wanting to target just the prostate and treat higher doses just to these internal tumors with radiation. But what if it's moving? And you know, here we use tens of thousands of microbeams to shoot at different targets, but what if it's moving? You may know that, and most of you, if you've had prostate cancer, have gotten MRIs. Well, one of the initial pitfalls with MRIs is that, and this is 10, 15 years ago, they weren't any good for imaging prostate cancer. They didn't realize at the time the fact that the prostate moves around a lot. At first, they thought it didn't. And that's why MRIs are the best, you know, treating or imaging bones which don't move. But they learned the prostate moves around a lot, and they had to strengthen their magnets from 0.5, now they're all the way up to 3 Tesla magnets. And now they can image the prostate, but it moves. Why does it move? Well, everything around it moves. The bladder sits on top of it, I'm showing you here, but it also falls in front of it, and the bladder is pulsating. The rectum, which I can't show you in this diagram, is behind it, and it's pulsating. You got the diaphragm down here moving, and then you have small bowel and large bowel on the side of it, which is moving all over the place, and that moves the prostate. So all of these factors move the prostate, even a degree of pelvic breathing. So, you know, you put your finger between your belly button and your groin, you move more than a dot, and that's all that matters. So we figured this out, and we now use a dynamic form of radiation which tracks your body's motion so that we can move with your body in real time. And so that's what DART is. It's a dynamic system. Okay. Is there anyone else? She's asking about the length of therapy. So I would say on average, it's about 6 to 7 weeks. And Monday through Friday, a treatment takes 10 minutes. You know, you're 8 to 10 minutes. You're in and out of our department. We're pretty efficient. It's about 15 minutes coming into the parking lot and leaving. I do believe that the longer treatment course, I'm not ever going to give that up because we do have long-term data with it. And anytime someone uses a shorter regimen, you know, it's more convenient for sure, but you pay the price as years go by, and you cannot find a single scrap of data which has ever shown that shorter regimens don't have increased toxicity over time. They may say, oh, it's acceptable. Not really. You know, if you're one of the few percentage, you know, and it's more than a few, you know, that's not acceptable. You're the guy who has a hole in your rectum or bladder, and it's a problem. But, you know, it's a problem because insurance companies don't want to pay for long courses of radiation. And so what happens is, you know, the doctors say, well, you know, we're just going to give it a shorter period of time. And this is what goes on. And plus they incentivize by paying a little more for those shorter regimens. Anyhow, I do believe that the longer course, you know, has been time tested, and, you know, and that's just the way it is. I know, for example, that with my patients, if they go somewhere else after treatment and are evaluated by a urologist or any kind of doctor, and they feel the prostate, and if they didn't tell them they had radiation, they would say, oh yeah, your gland is pliable, it's smooth, I don't feel any nodules. That's what we feel. The fact is, though, if you have these rapid courses of radiation, it creates scarring, you know, and you end up having, they'll tell you, oh yeah, it's really hard, it's scarred, or, you know, just diffusely indurated, those kinds of things. So I do think the longer courses are better. Yes, sir.
I didn't quite get that. If it's short
shorter, it's more scarring because they use a more powerful dose? Yeah.
Yes, shorter, more powerful dose each session.
I understand.
Okay. Yes, sir. Okay. Yes, sir.
I was just wondering, I don't know the specifics, but a friend of mine supposedly got Facebook. I guess he had a urination problem. So, and then talking to friends, because I haven't seen this guy that I know, but talking to friends, I said, hey, how's Hoppy doing? He's urinating like a 8-year-old. So what do you think they did to him?
Well, he's asking, he has a friend who had a lot of urinary symptoms, but now he's all really good and must have had a procedure, is what you're saying. Generally speaking, the different procedures that are done are all developed to reduce. One of them is called a PVP. I've published on it. It's in the rear there. It's photoselective vaporization of the prostate. It's not cutting, okay? But what it does, it vaporizes the tissue, and the tissue you typically want to vaporize is right around here. That tissue I told you that can protrude, that can, cause the bladder impingement. And you just basically ablate this tissue right here, and that's one way. Another way is something called aquablation, where you use water and you heat the water to lessen the size of the gland. And that's fairly popular now. I think that's okay. I think one of the ones that I don't like is called a TERP. And it's just basically a rotor-rooter. And you go in here and you just bore away. And the problem with that, there's many, is one is that when you do the rotor-rooter, you start eroding also into this bladder sphincter. And that sphincter muscle, again, you've been relying on your whole life to control your urine. What happens if you remove it? Well, then you're not controlling your urine and you start getting leakage issues. And so that can be an ugly situation. The second thing is, because you are rotor-rootering it, with a blade, you're causing a lot of blood dispersion. And it has been documented that men who didn't even know they had prostate cancer, it was spread by the TURP. And so he probably had, I don't know, it could have been an aquablation, it could have been the rotor-rooter. But in all those cases, the guys will typically say, oh, I'm peeing like a racehorse, like an 8-year-old, for a little while. Because what ends up happening is this area that was removed, it starts scarring up and then closing up again. So typically for those men who need a procedure like that, they'll be getting another one. Maybe not immediately, but years from that one. But that could still be good, if it really helps with urination. There's nothing wrong with that. Okay.
Speaking of that,
Okay. Yeah, you got to get treatment. All right, I'll take one more question. Yes.
Speaking of insurance, how is it looking at doing this test to be proactive? I mean, are they on board with it? Because I know years ago, if you took them and it came back showing all that, it's like they dropped you like a hot potato.
I'm not sure. Are you saying pre-existing?
No, like the 1 and 2, like doing
Oh.
testing and stuff like that. Are insurance more open to having that done
So
today versus, years ago? Because I've had it on my mom's side of dealing with that, and she went with it, and I didn't test because they told me if I came up with it, I wouldn't have insurance. I'm not aware.
yeah, so she's asking about insurance and doing these genetic or genomic tests. So if you have prostate cancer or a cancer anywhere in your body, and you do a genomic test, which is the one looking at the cancer itself, is it making anything different? Insurance is going to pay for it and they won't hold it against you. However, and this is something that's really important, and I tell my patients, if we're testing you for a germline tumor, and that means it's in your genetics, it's in your, you've had it since you were born. Well, if the children have that too, and the insurance finds out, they'll never get life insurance. Yeah, it's really unfortunate. But and if you did, they'll drop you like a hot potato. So we generally recommend, if you have a germline tumor, before you even find out. Get life insurance. Now, other insurances, health insurances, they can't drop you, but life insurance will, and that's very unfortunate. But so, you know, for example, if you happen to have a cancer and you feel, oh yeah, I got a lot of members of my family who have cancer, maybe my children have it too, which we recommend they get tested. But before they get tested, get life insurance. Otherwise, we'll never get it again. At least now, in this era. Okay. Well, thank you all for coming. We'll be doing this again in a month.